welcome to a new session of clinical pharmacology. I am Dr. Khalid Hassan, Associate Professor of Clinical Pharmacology and Drug Therapy in clinical research. Okay, speaking about antimicrobial therapy in part one introduction, as you mentioned already, antimicrobial therapy is going to be several parts. We are going to cover the entire topic about antimicrobial therapy, start from antibiotic, antifungus, and antiviruses, antiprotozoa. So we'll start with the introduction, session one or part one about the antimicrobial therapy. So antimicrobial it's indicated to the drugs that used to treat microbial infections. So we have microbial infections here. And this microbial infection could be bacteria, could be viruses, could be fungus, or could be parasites. Antimicrobial drugs belong to the medications that are used to prevent or to treat infections. So we can use it for the treatment, or we can use it for the prevention of the disease, not only for the treatment. So we classify or categorize the medication in several groups. We have antibiotic, antiviral, or antivirus medication. Then we have antifungis, antiparasite. Okay, antimicrobials, we have another important raised issue about resistance. So we have several microorganisms now resist the antimicrobial. It's like a global issue here due to the antimicrobial malpractice or abuse. The resistance occur because the bacteria, viruses, and parasite no longer responds to the treatment. This may be resistance related to the medication become ineffective. Number one, there's some explanation mechanism. Number one. Number two, the infection become difficult to treat. So the medication become ineffective. This is the one options or one reason, one explanation. Another explanation, the infections become difficult to treat, and there's a risk of spread of the disease, and this will lead to the severe illness. Some patients suffer from disability, and other patients may die from the infections. So the increased resistance towards the antimicrobial is like global issue. So it's very important to regulate the practice of using antimicrobial to prevent antimicrobial resistance. Antimicrobial selections depends on several criteria. As you can see here, it's required from the prescriber, from the healthcare provider, from the physician, knowing the following or knowledge in the following section. Number one, confirming the presence of infections. Does the patient has infections? What is this infection? Is this infection related to the bacteria or viruses, fungi, parasites? Number one. Number two, we need to identify the bacteria. Is this gram negative or gram positive? Is this like bacilli or cocci? Is this that we need to identify by the cell culture or blood culture or some maybe lab work? Site of infection, is this infection in the brain or in the abdomen and the chest, urinary tract infection or chest infection, respiratory tract infection? Okay, patient factors, we need to look on the age for the patient, for example here. Patient factor, we need to look on the age, safety of the medication. We have some medication may cause ototoxicity or like nephrotoxicity. Cost of therapy. So we are going to cover all these maybe variables in the next coming slide. So confirming presence of infections, here we need to look on that. Does the patient suffer from fever or high temperature or hyperthermia? So hyperthermia or hypothermia is very important for us. Does the patient suffer from fever? What about blood test? We're looking on the white blood cells. Is the white blood cells normal between 4,000 and 10,000? Or the patient suffer from a high level of blood cells that indicate infections that could be bacterial or viruses or fungi? We look on the local sign on the skin, arrhythmia, tenderness, or like any abscess. Okay, the selection of antimicrobial depends on the several factors. We can look on the patient factors first, then we have other factors may be related. as you can see there. So we have several maybe criteria should be taken consideration. Patient factors. We ask the patient or the family, does the patient suffer from allergy, or penicillin allergy, or any other medication, sulfa allergy? So drug allergy history, drug history or drug allergy is very important. Age of the patient, because we know that with increasing age, the liver function will decrease, the kidney function will decrease. Pregnancy, we know that any medication may affect the fetus and may cause abnormalities or like fetotoxic. Genetic metabolism, also we are going to cover that. Renal and hepatic function, site of infections, concomitant drug therapy. Here we talk about drug-drug interaction. Very important topic, very important topic in pharmacology. Underlying disease. Okay. Uh, age determined like organism. We have here some example. Not all the bacteria affect the old age. It's in similar pattern. As you can see here, we are speaking about some examples. We have, when you have different age, we are going to see different type of bacteria. So when we have patients suffer from meningitis, for example, here the bacterial meningitis, and you are working on the clinic or the hospital. If you work on the children hospital, neonates and the infant, you are going to see specific type of bacteria. For example, in neonate we have group B streptococcus, E. coli, listeria in neonates. In infant, a childhood, Haemophilus influenza, streptococcus pneumonia, Neisseria meningitis. If you talk about adolescents, childhoods, you can see the Neisseria and streptococcus pneumonia. So different age of people may present with a different type of bacterial regarding the bacterial meningitis. Okay, antimicrobial agent in people above than 65 years of age, in person above than 65 years and above. The study showed decline number of nephrons and the kidneys. So the study showed a decrease in renal function. So the people here move maybe tends towards the decreased renal function or renal dysfunction there. So the situation will lead to the increased incidence of adverse drug reactions caused by antimicrobial that eliminated through the renal system. So if you are using any medication eliminated through the renal system, you need to take this in consideration. Okay, genetic and metabolic abnormalities. This is very important. The highlight is like give you some example what happened in the human body. So genetic and metabolic abnormalities, here you can see here we have some people considered like slow oscillators. For example, when you try to treat tuberculosis, we prescribe isoniazid. Isoniazid, they found in this group of population that considered slow oscillator, we have increased risk of peripheral neuropathy. So for this reason here, we have to identify, is this patient slow oscillator or fast oscillator or normal oscillator? So isoniazid, they found isoniazid increased risk of peripheral neuropathy in a slow oscillator patient. Moving to another case, also some maybe patients suffer from deficiency of glucose 6-phosphate dehydrogenase G6PD. If we have deficiency in this enzyme, those type of people may be at risk of developing hemolysis, and this due to the exposed to the drugs such as sulfonamide, nitrofurantoin, and naldexic acid, anti-malaria drugs. So we need to take this in consideration. If the patients suffer from deficiency of G6PD, there is a risk of anemia, hemolytic anemia, due to the treatment of the sulfonamide or bisulfonamide, nitrofurantoin, naldexic acid, or anti-malaria medication. Dapsone, for example, also another case. Looking on the leukocyte antigen histocompatibility agent HLA-P 5701, this type of antigen, human leukocyte antigen HLA-P 5601, if the patient treated with the antiretrovirus drug Abcafar or Abacafar, this will lead to the severe hypersensitivity reaction. It's not all patients suffer from severe hypersensitivity reaction, but they found the person or the people suffer from maybe carrying this type of antigen HLA-P5701, they increase risk of hypersensitivity reaction, severe hypersensitivity reaction. Okay, so in the previous slide we covered the age effect on the antimicrobial treatment. In the next coming slide, we are going to speak about the effect of renal and hepatic function on the antimicrobial therapy or treatment. So, if the patient suffer from decreased renal or hepatic, if the patient suffer from decreased renal or hepatic dysfunction, okay, decreased function of hepatic or renal, what happened here? We have alteration on the pharmacokinetic, because we know that renal or kidney responsible for elimination. Uh, uh, on the other side, liver is merely responsible for the metabolism. So here, if the patient suffer from dysfunction of renal or hepatic function, the result will be alteration of pharmacokinetic process. So we are talking about elimination or metabolism. So if the patient suffer from decreased function of these two organs, the result will be alteration, changes in the pharmacokinetic, changes in the metabolism, or changes in the elimination. This will lead to what happened here. For example, when you have decreased function of the kidneys or renal, this will lead to the accumulate of antibiotic and increased exposure to the antibiotic. Increased exposure of the antibiotic, this will maybe let us think about the effect of increased concentration of antibiotic in the blood, and this may cause like toxic effect or adverse drug reaction. Okay, so we are going to cover that with some example. Dose individualization and therapeutic drug monitoring. So in this case here, what we need to do, we need to adjust the dose. We need to implement renal function, renal test, renal function test, and liver function test to determine, do we need to adjust the dose for this patient? Do we need to adjust the dose for antibiotics? So we have some example in the next coming slide. Okay, here we have some examples for antibiotics that may require dose adjustment. So some antibiotic require dose adjustment in patient with renal and hepatic. So we are going with the first maybe two slides. We are going to cover the renal dysfunction, and another slide to speak about renal liver dysfunction. Here we have some important example for the dose adjustment needed for the patient with renal dysfunction. The first medication, vancomycin. Vancomycin, this medication work on the cell wall by inhibiting the cell wall of bacteria. Vancomycin associated with increased risk of nephrotoxicity. Vancomycin increased risk of accumulation in patient with the impaired renal dysfunction. So what happened there? So that if you have patients from renal impaired renal function or renal dysfunction, we need to adjust the dose for vancomycin, because vancomycin carry the risk of nephrotoxicity. Okay, this is number one. Moving to the maybe another example here, aminoglycoside. Aminoglycoside also increased risk of nephrotoxicity in addition to the ototoxicity, which mean affect the inner ear, could be the hearing, could be the balance for the patient. So aminoglycoside need to be adjusted doses in patient with the renal dysfunction, because aminoglycoside increase risk of nephrotoxicity and ototoxicity. Another example, important example, trimethoprim and sulfamethoxazole. These medications should be avoided with the large doses, because the increased risk of side effect related to the liver, related to the renal dysfunction. Here we have some references. I would like to stop here a little bit and share with you the references from the articles, vancomycin, aminoglycoside, trimethoprim. Okay, let me share the screen with you about the vancomycin, and I'm going to make it a little bit large, and so everyone can see it. And this is a information leaflet for vancomycin, and you can see vancomycin here for injection, for intravenous use, and initial treatment. This is from the website. It's not belong to my slides, for example. What we can see here, indications. I'm not going to speak about the uses for the medication, but I'm going to speak about renal function. Do we need to look on the renal function for the patient here? Okay, so I will maximize, scroll down. So you can see here what they said. Patient with renal impairment. I'll make it bigger a little bit. Okay. Patient with renal impairment. See for prescription information. I will scroll down a little bit. Okay, and this is the dose. Dosage in adult with a renal with normal renal function. Okay, I will go to the patient dosage in patient with renal impairment. Okay, so we can read it together here and need to look what we have here. Okay, what they said in this slide here on this leaflet information: dosage adjustment must be made in patient with renal impairment. So it's very important. A dose should be adjusted no less than 15 should be no less than 15 milligram per kilogram in patient with any degree of renal impairment. So this one shows us the importance of adjustment dose in treatment related to the treatment with the vancomycin. Okay, so again, vancomycin, this medication here, and we have the indication. We use vancomycin for patients suffer from septicemia, patients suffer from infective endocarditis, skin infections, bone infection, and lower respiratory tract infection. Moving to the next medication here, you can see the gentamicin. Gentamicin is like we are here to cover the renal function here. Okay. Okay, this is a renal function. You can see here we can prescribe it for patient with normal renal function. We have some instruction. What happened to the patient with a decreased renal function? Okay, so you can see here patient with impaired renal function. What they said here: dosage must be adjusted in patient with impaired renal function to assure therapeutic adequate but not excessive blood level. So it's very important to maybe prescribe and adjust the dose in patient. Again, the last medication on the list here, Bactrim. Bactrim is like a combination treatment of sulfamethoxazole and trimethoprim. Again, if you click on the renal here, okay, so we need to adjust the dose in patient with renal dysfunction. Okay, so this one here for the Bactrim sulfamethoxazole. This is a patient with adult and pediatric patient. Patient preparations, and then we have the strengths. I will go back again to look on what we have. So you can see the recommended dose according to the creatinine level. So patient with impaired renal function, dose should be adjusted according to the creatinine level. A creatinine above 30, between 15 to 30, below 15. And you can see above 30, usual standard dose. Between 15-30, we prescribe half of the normal dose. Below 15, not recommended. This is very important for the patient who suffer from renal dysfunction or decreased renal function. Okay, so we're done with the medication. Some example for medications, some example for the medication given to the people suffer from renal dysfunction. We have 3 examples here. We have vancomycin, aminoglycoside, and trimethoprim sulfamethoxazole. Okay, we have the reference here. We discuss all these 3 references with you. Moving to the next important organ. This is a major organ responsible for drug metabolism. As you can see here, we have several medication highlight. These medications mainly metabolized by the liver. This medication may cause liver toxicity. If the patients suffer from liver disease, we need to adjust the dose. The first medication, azithromycin, the second clindamycin, erythromycin, metronidazole. So we have list of medication here, as you can see on the screen. Metronidazole considered contraindicated. That means it's not allowed. Contraindicated. That means it's not allowed to prescribe to the patient with a history of cholestatic jaundice or hepatic dysfunction, especially with the prior use of azithromycin. So we don't recommend to use this medication in patients with liver dysfunction or hepatic dysfunction. Clindamycin may cause two types of hepatotoxicity. The first type is associated with the increased liver enzyme, increased transient serum aminotransferase elevated after several days of treatment of IV in doses. So when you prescribe clindamycin, a few days of the treatment, the liver enzyme will be increased. Okay, and another type of hepatotoxicity associated with the clindamycin could be acute idiosyncratic liver injury, and this one occurred during 1 to 3 weeks of the treatment of starting therapy. So clindamycin may cause hepatotoxicity. Two types of hepatotoxicity. The first one could be a transient elevated level of liver enzyme during the first several days of the treatment, but after 1 to 3 weeks of treatment with the clindamycin may cause acute idiosyncratic liver injury. Okay, clindamycin. Moving to the next group of medication, azithromycin. Azithromycin metabolized by the liver and biliary excretion and require caution in patients with significant renal dysfunction due to the accumulation of erythromycin. So erythromycin and another medication need to be adjusted dose in the patient there. Metronidazole, another medication also, patient with hepatic metabolism. Metronidazole maybe slowly with a resultant accumulation. This will lead also to the accumulation on the plasma. So for this reason, we need to decrease the dose in patient with the liver dysfunction. So 3 examples here. For example, azithromycin, clindamycin, erythromycin, metronidazole. I would like to indicate here we have 2 medication. Azithromycin, erythromycin belong to the macrolide medication. Okay, so erythromycin belong to the macrolide antibiotic. Here we have 3 references maybe to share with you about azithromycin and liver dysfunction or hepatic dysfunction. Okay, this is azithromycin tablet oral suspension available like oral suspension and tablet, and we need to look on the liver. So if you maximize it a little bit about Zitromax, so we can only share with you some of these. For example, here we have hepatotoxicity, severe and sometimes fatal. Hepatotoxicity has been reported. Discontinue of Zitromax immediately if we have signs of hepatitis. So as Zitromax or azithromycin may cause hepatitis. This is number 1, and those need to be adjusted. Clindamycin, we have as we maybe mentioned already regarding the clindamycin. Clindamycin, if I go to the home, look what we have here. Clindamycin and the maybe published in the National Library of Medicine. We have clindamycin has been linked to the 2 forms of hepatotoxicity. We have the first type of hepatotoxicity related to the elevated level of liver enzyme occurred during several days of treatment. We have another one, acute idiosyncratic injuries. So as you can see here, most of the information on the slide coming from the article and journals, and we have some supported references. This is very important to cite and bring references for your citation. Okay, for your text, metronidazole, brand name Flagyl. Okay, if you click on this one again for metronidazole, we can look on the metronidazole. Okay, metronidazole, here we have Flagyl, here metronidazole tablets. We are not here to discuss the indication and uses because we are going to cover that in the other session or other lecture, another lecture with you. So I will click here and type liver. Okay, so again, it's much better to type. Like you can see here, risk of hepatotoxicity and death in patient with this is another maybe specific type of liver disease. I will go to the hepatocyte, hepatotoxicity. So you can see here the metronidazole associated with the risk of hepatotoxicity, but this is a rare case and could be lead to the acute renal failure. So we have here several examples related to the hepatotoxicity or hepatic dysfunction. If the patient suffers from hepatic dysfunction, we have to be careful. So the question now, which of the following medication should be prescribed carefully or should not be prescribed with to the patient with severe hepatic dysfunction? So azithromycin, clindamycin, erythromycin, metronidazole. So what is required? Number one, the first choice for us, okay, decrease drug dose. If the patient suffers from severe hepatic dysfunction, okay, stop, or like this one considered like contraindicated. It's not allowed to prescribe this medication to your patient. Okay, moving to the next important slide here, it's like drug-drug interaction with the antimicrobial. We have some drug-drug interaction, some important example here. If the patient suffer from epilepsy and the patient already on phenytoin and this medication for epilepsy, this medication need to prescribe isoniazid due to the infections such as TB. So if the patient suffer from epilepsy and we prescribe phenytoin to the patient come back to the clinic and he has history of tuberculosis and you prescribe isoniazid, and the result of drug-drug interaction between phenytoin and isoniazid, this will lead to the increased phenytoin toxicity, and they said that isoniazid inhibition of phenytoin metabolism. So what they found here, isoniazid inhibit metabolism of phenytoin, and this will lead to the increased toxicity of phenytoin. So if the patient suffer from epilepsy and the patient treated with phenytoin, and the patient come to the clinic recently suffer from tuberculosis and you decide to prescribe isoniazid, we need you to remember that isoniazid inhibit metabolism of phenytoin and increase risk of toxicity. This is number one. Number two, very important, popular in the practice here. For example, let me say we have patients suffer from heart failure with edema, for example here, and the cardiologist placed him on the furosemide as the loop diuretic, some furosemide, and for some reason the patient come to the hospital due to the urinary tract infections, and the paramedics prescribe aminoglycoside to treat the urinary tract infections. But we need to bear in mind that aminoglycosides such as gentamicin increase risk of ototoxicity. At the same time, furosemide carry the risk of toxicity. So we have two agents may cause ototoxicity. Number one, we have furosemide. Furosemide cause ototoxicity, ear toxicity, maybe decrease the deafness or the hearing loss. Okay, or like imbalance. Furosemide may cause ototoxicity. On the other hand, they found that aminoglycoside may cause ototoxicity. This one, we call this one like adjunctive therapy, adjunctive uh, adverse drug reactions. So synergistic effect. So two medication cause the same side effect. We recommend to avoid the medication. For example, instead of using aminoglycoside, we can go with for example, with a ciprofloxacin for this patient. Okay, the next medication also here we cover the ototoxicity here. Moving to the next medication, the next medication will be aminoglycoside and vancomycin. Here, two antimicrobial, two antibiotic. If you combine aminoglycoside and vancomycin together, this will lead to the increased risk of nephrotoxicity. The reason for that, or clarification for that, because aminoglycoside cause nephrotoxicity, vancomycin cause nephrotoxicity. We don't recommend to use two medication may cause the same toxicity. We need to maybe select another medication that save the kidneys and not aggravate the side effect. Okay. Moving to the fluoroquinolones and tricyclic antidepressant, macrolide, antipsychotic. So fluoroquinolones, like medication used for UTI, urinary tract infections, could be for respiratory infection or abdominal infections. Fluoroquinolones, if you combine fluoroquinolones with the antidepressants such as tricyclic antidepressant or macrolide or antipsychotic, this medication may lead to the prolongation of QT interval on the EKG. Okay, so for this reason here we have to be careful if you have patients from heart disease, not to prescribe this medication to the patient. Okay, so the situation here. So if the patients are from heart disease, there is a risk of a prolonged QT interval. For this reason, we don't recommend to prescribe fluoroquinolones with tricyclic acid antidepressant, tricyclic antidepressant, macrolide, or antipsychotic, because the risk of prolongation of QT interval. So this we have here like another important drug-drug interaction with the antimicrobial. For this reason here is very important to obtain drug history from your patient before you start your treatment. So look on the drug history. Does the patient take any medication? Does this medication interact with your prescription, antimicrobial prescription? You have to take this in consideration. Okay, coexisting disease. If you look on what we have here, if the patient, for example, suffers from diabetes mellitus, this patient may be at risk of peripheral vascular disease, increased peripheral vascular disease, and this will lead to the increased development of infections in the lower extremities. So diabetes mellitus, increased risk of peripheral vascular disease, and this will lead to the increased risk of infections. Okay, changing peripheral blood flow. If the blood flow change, and we have the immune function will be changed. So here we have diabetic patients are from infections, and we have two things. We have immune function will be affected. What we have the decreased peripheral blood flow. Okay, when we have these two issues there, we have impaired blood flow, impaired immune function. The situation here will be we are going to have infections, difficult to treat. Okay, so we need to take this in consideration. Okay, thank you everyone for your time, and this will lead to the end of first part of antimicrobial. Next, we are going to speak about maybe some characteristic of antimicrobial therapy, such as maybe select of antibiotic. We are going to speak about spectrum of antibiotic, combination of treatment, safety of the treatment, route of administration, cost of therapy, and so on. And when we finish this introduction, we are going to start with a group of medication according to the site of action on the cell wall, cell wall, bacteria cell wall, or protein cell wall, or like metabolism pathways, or like nucleic acid pathways. So we are going to look on the bacteria according to the site of action on the bacterial cells. Thank you so much for your time and have a great day.